안녕하세요. 국경없는의사회 활동
Hello.
브리핑 포커스 시리즈.
Thank you for taking the time to participate in the MSF Briefing Focus Series Emergency Response Briefing of the Rohingya Refugee Crisis. I am Tae-Eun Kim from MSF Korea, and I'll be moderating today's event. Please note that we are providing simultaneous interpretation, so please choose Korean or English by clicking on the button below the screen if you need interpretation service. Today, August 25th, marks the 5-year anniversary of 700,000 Rohingya refugees evacuating from Myanmar, fleeing from the persecution they suffered. Today's briefing has been planned to share with you the long history of the Rohingya refugee crisis, the current situation of Cox's Bazar refugee camp in Bangladesh, where more than 1 million Rohingya refugees are living, and the medical assistance activities MSF is doing in the area. We hope that today's briefing will provide you with an opportunity to gain a deeper understanding of the Rohingya refugee crisis and their relief efforts. First, we will hear from Mr. Jason Mills, Humanitarian Advisor at MSF, on the work to support Rohingya refugees and get some answers to the questions you raised. While listening to the presentation, if you leave a question in the Q&A section at the bottom of the screen, we will try our best to address them during the Q&A session. Now, allow me to introduce to you today's presenter. Advisor Jason Mills joined MSF in 2007. He has worked in various MSF relief sites starting in Sierra Leone, Darfur, Sudan, South Sudan, Bangladesh, Ethiopia, Chad, Syria, and Myanmar. He has worked in various sites, and from 2016 to 2019, he has played a key role in advocating humanitarianism and raising awareness related to MSF's work to the U.S. government. Earlier this year, he has begun to serve as the humanitarian advisor, focusing on humanitarian issues, including the Rohingya crisis in Asia. Personally, for me, he is also a great colleague from whom I can learn about MSF's advocacy work and gain better understanding of Rohingya refugees. So it is very meaningful for me personally to have him with us today. Now, let's hear from Advisor Jason Mills.
Good morning, everyone, or excuse me, good evening, everyone. I am calling in today from the US, so it is a bit early for me here. If you see me sipping my coffee, I apologize. I would like to thank my colleagues in Korea for inviting me to speak with all of you today. And I'd also like to thank all of you for joining us to learn more about the Rohingya. I look forward to having a good discussion and to answer any questions that you might have at the end. I've prepared a short presentation which focuses quite heavily on the history of the Rohingya, because this is very important to them. When we speak with the Rohingya in the camps, they often really want to talk about history, because after being made stateless in 1982 and losing their citizenship in Myanmar, previous recognition of themselves as Rohingya in history is a very important subject. So I thought today, being the 5th anniversary of the beginning of the violence in Rakhine, which drove 700,000 people into Bangladesh, as well as being a year which is 40 years since they lost their citizenship in Myanmar, that it's important to focus a bit on the history as well as our medical programs. So without further ado, I will share my screen and begin the presentation, and then we will have a Q&A session, I believe. So bear with me here. After 2 years of the pandemic, hopefully I can share my screen effectively, but you can't take anything for granted. Okay, so I recently had the opportunity as well to revisit Bangladesh with Tae-Eun, and we were there in June, and it was quite powerful to return after having been gone for 10 years. When I was there previously, there were 40,000 unregistered Rohingya refugees and 20,000 registered, and then we returned in June, and it was quite overwhelming to see a camp of 1 million people, and it really struck home to see the overwhelming situation. So without further ado, let me start my slides. So if we look back, the Rohingya themselves are a stateless ethnic group who have lived for centuries in northwestern Myanmar, excuse my typo, and they're also known, which is also known as Burma. They live actually in an area that's highlighted there on the map, and I'm not sure if you can see my pointer as well, which is Rakhine State in Western Myanmar. And historically, Rakhine State was actually the kingdom of Arakan. It was actually conquered by the Burmese in the central heartland in the 1700s only. But prior to that, for 500 years, it was an independent country, which was actually largely oriented towards the west rather than the east. And it's one of those fault lines in the world that kind of goes back and forth between different regions, particularly after the Burmese colonized it and then after the British colonized Burma. The Rohingya themselves are a Muslim minority that lived there for centuries. They are one of the most persecuted minorities in the world. Due to the ongoing violence and persecution, hundreds of thousands of Rohingya have fled to neighboring countries over the last decades. And you can see the diaspora groups and the refugee groups within this map here from Al Jazeera. There's 200,000 or more living in Saudi Arabia. Most of the Rohingya that went to Saudi Arabia actually were there, went in the 1970s. They were invited by the then king of Saudi Arabia and have been living there for centuries. Pakistan as well. A lot of people migrated to Pakistan in the 70s, 80s, and so forth. But the 800,000 in Bangladesh is much more recent phenomenon, as well as the migration and seeking refuge throughout the Andaman Sea area. October 15th of this year actually marks the exact date in which the citizenship law was enacted in Burma, which stripped the Rohingya of their citizenship in Myanmar. Prior to that date, they were citizens of Myanmar. They had representatives in the government after the British left Myanmar, or Burma at the time, and it was taken away from them. So if you can imagine having your citizenship and identity taken away and all of the challenges that would then create for you in Korea to open a bank account, to buy a transit card, or all of those things, these are similar issues that you have in being stateless. You don't have legal standing. And if we look at the more modern history of the Rohingya, when the troubles really began to pick up steam in the 1970s, the Burmese army at the time had an infamous campaign called Operation Dragon King. And it was, quite a horrible mass arrests, persecution, horrific violence. And over 200,000 Rohingya fled across the border to Bangladesh. And they didn't stay there long, because by the end of 1979, most were actually forcibly repatriated to Burma, which basically means they pack people up and they put them on trucks and push them back into Burma, whether or not they like it or not. MSF actually sent a team in 1979 to assess the situation. We were a very young organization at the time. They arrived, but not in time to do anything of consequence, except for become exposed to the plight of the Rohingya. And here I also note obviously they're in the 70s. This was the time when Saudi Arabia and Pakistan, a lot of people started seeking refuge and a new life there. But those migration or refuge routes, depending upon the situation of the individual at the time, was cut off largely later on. So as we move into the later on, so after the military crackdown that follows and the suppression of popular uprising, the country was renamed Myanmar from Burma, though some countries like the US and the UK still refer to Myanmar as Burma. At the time, the ruling State Law and Order Restoration Council actually really increased its military presence in northern Rakhine, and the Rohingya were reportedly subjected to compulsory labor, forced relocation. Rape is very common. summary executions and torture. There are some really moving personal accounts of what it was like to live in Burma at the time. It's difficult history to read, let alone to live through and to experience. And you know, one thing I'd just like to note for you to remember as we go through these slides is that when you talk about trauma is something that's cumulative. Trauma builds up over people's lives, and trauma can be passed from one generation to another. So when you think about how much the Rohingya as a people have been affected over the last 40, 50, 60 years by having to live under such type of persecution, that begins to impact the very fabric of their society and perceptions of the world, and to have to live through and pass on that much suffering has tremendous negative health consequences for people. So just bear in mind that these things don't go away just because they happened a long time ago. In the 1990s, we first began to work extensively with the Rohingya ourselves as an organization. We opened a project in Bangladesh in 1992, and we opened up in Rakhine State in 1993. MSF was the first actual international international non-governmental organization to gain access to Myanmar in the early 90s. And we were also one of the first inside Rakhine. From 92 to 96, nearly all of the Rohingya that had been driven into Bangladesh by the most recent crackdown were actually forcibly repatriated to Myanmar again, which left only 33,000 officially recognized refugees in Bangladesh by 1996. As you can see here from this camp, this picture of this camp, Dumdumia in Cox's Bazar, these are shelters behind them. They're living in small shelters with some rice sacks put over them that are made out of twigs and branches, and are actually, you know, as rough and makeshift as you possibly can imagine. The horrific shelters that they still live in, which you'll see pictures of later on, are actually much more advanced than this. So in the 2000s, there was 33,000 registered refugees remaining in Bangladesh. However, there was at least 200,000 actually in Bangladesh living as unregistered refugees. And while we closed our programs in 2003, we reopened them in 2009 because, as you can see in this picture, this is the unregistered refugee settlement in Kutupalong. You can see the shelters are built out of mud with bamboo and plastic sheeting. It's an improvement upon what people were living on in the 1990s, but it's still a horrific environment to live in. And one of the reasons we reopened our programs is we discovered that, I mean, basically the sewage from the registered refugee camp on the hill was flowing downhill into the unregistered refugee camp and causing disease outbreak and diarrhea outbreaks. And nobody was providing them with any assistance whatsoever. They were living completely illegally inside, considered illegally in Myanmar, not recognized as refugees or having any rights whatsoever. So we reopened in Bangladesh in 2009, and large medical programs in Rakhine continued throughout, so from 1993 to present day. From 1993 up until 2012, MSF in Rakhine was largely very quiet. It was a very difficult environment to work in. And we never published very much about what we did there because maintaining our access inside Rakhine, Myanmar was extraordinarily difficult. As you'll recall from the Myanmar history up until 2012, 2014, where you saw Aung San Suu Kyi and the NLD starting to come into power and political change in Myanmar. Though that brought additional issues inside Myanmar, which I will get to, I believe, in the next slide. So in 2011, we issued one of the better reports we've ever done on behalf of the Rohingya. At the time, we actually released this privately. It wasn't a public document in 2011. It was handed out in diplomatic circles, sometimes without even MSF's name on it, because we were so worried about losing access inside Rakhine State. And basically, the bulk of this report is it shows how in Myanmar, the being stateless impacts a woman's health outcomes by the fact that, you face potential prison for having children without official marriage license, but you have to pay a bribe to get a marriage license. You have to pay to get a child. You have to pay to get a birth certificate. So none of those things are simple and straightforward if you're stateless. So that results in a high level of abortion within the population there. But because they also don't have access to medical services in Rakhine, they oftentimes those abortions have to be quiet abortions, illegal abortions at home. And what we found was horrific, that at least 14% of women had abortions, and not in of itself an issue if you can have a safe one, but 83% of the women that were having abortions were having to use a special type of stick by untrained midwives, basically. Traditional birth attendants, which is just an absolutely horrific way to do it. And another part of the report showed a nutrition survey from Kutupalong in Bangladesh, which showed that unregistered refugee children had a much higher rate of malnutrition than registered refugee children or the host community, because there was a lot of denial at the time in Bangladesh that the unregistered refugees had any negative health outcomes from their situation. We actually documented it and proved that. And I was actually working in the project at the time and was involved in getting that survey done. Under quite some challenge, because we were actually had lost our permission to work in Bangladesh. We're continuing to work there sort of semi-legally because the government of Bangladesh was mad at us because we had issued a press release in 2010 drawing attention to the fact that the unregistered Rohingya refugees actually legally had no rights and were suffering greater than the registered refugees, which up to that point had been something that was not discussed publicly. But we managed to maintain our access, and our programs never closed. And we actually managed to continue to expand our programming in Bangladesh. An interesting footnote on our programming in Bangladesh: in 2011, we started the maternity ward for the unregistered refugees, and also invited the host community to deliver birth there because there weren't a lot of options. We started off with a couple dozen births per month in 2011, and I think at the moment we're assisting almost 3,000 or 4,000 births a year in Bangladesh. It's quite impressive growth of the program. Now back to Myanmar. 2012, 2014 was a pivotal moment in Myanmar. With significant intercommunal violence in Rakhine. There was the burning of houses and villages, and there was 130,000 Rohingya displaced from their villages in one of the largest mass displacements in recent decades. And this was all sparked a lot also by the emergence of social media and the rapid escalation of people having access to the internet for the first time in Myanmar with the political change. So on the one side in Yangon, everybody was thrilled that Myanmar was becoming more liberal and that everybody could suddenly have free access to the internet. The problem is when you have millions of people that have never been on the internet and don't have any media literacy, rumors and fear-mongering on Facebook actually become fact. I mean, we struggle even in modern, in the United States, where I am right now, with this information and media manipulation of the population. Can you imagine in a country that has no access to the internet prior, like how much people take at face value what they read on Facebook? And that actually was proven to be a targeted, manipulated campaign by members of Myanmar military at the time. So that was an engineered social crisis. And part of that was targeting of MSF as well. You can see these pictures here, AZG Get Out. In Myanmar, we're actually still known by AZG, which is our Dutch acronym, Arts on the Grenzen, because we went in as MSF Holland in the early 90s in a different era. So these people were actually protesting outside of our office and wanted us to leave Rakhine State. And briefly, we were actually suspended in Rakhine because we were seen as a pro-Rohingya organization within this greater context of ethnic violence and media manipulation. Moving on, obviously 2017, exactly 5 years ago today, was the peak of the beginning of the peak of the violence. We conducted mortality surveys in Bangladesh that showed that between August 25th and September 25th, at least 6,700 Rohingya were murdered in Rakhine State, about 750 of those children. We do believe that through these mortality surveys, that's probably the minimum. And the truth is the numbers were quite higher, because in order to be interviewed and qualify for that number of 6,700, that means there had to be family members that survived. So that number doesn't incorporate any situation in which an entire family was killed. So the number is certainly far higher, but that's epidemiologically verified number based upon the science. So that wave of violence displaced over 700,000 Rohingya into Bangladesh in 2017, in the largest population displacement in modern Asian history. There's still today over 900,000 Rohingya in Bangladesh. They're dependent upon humanitarian assistance, and they're living in camps just across the border in Cox's Bazar. The camps are surrounded by razor wire. They have very limited opportunity to work, to get education, to really do much. It's kind of like living in purgatory. And that's what people tell us when we were there. They said, you know, and one guy, he was an elderly man. He said, you know, I'm an old man. I don't have much time left in the world, but I worry about the children, and what are they going to do? Because they, you know, what is the hope for their future? How do you tell them to be hopeful and to look for opportunity when there is none, because you have nothing? So it's very deeply moving to hear their stories. And we'll be publishing today as well some testimonies from people in the camp from 5 different generations, which you can see and you can hear in their own words. You don't have to listen to me, which are quite touching and moving. So in 2017, you know, marking the moment also when the majority of the Rohingya population who are native to Myanmar were forcibly displaced into Bangladesh. So now the majority of the Rohingya population in the world actually almost lives in Bangladesh, instead of back home in Myanmar, where there remains only about 600,000. So it's a total shift in population dynamics, and the UN rightfully stated, you know, it's a very textbook definition of ethnic cleansing. So that's a bit the history, and I'm happy to dive more into that. I tried to keep that basic. I see that I did not get rid of my question mark on whether or not that's a photo from Gematoli Hospital, but it is a photo from Gematoli Hospital. Talking a little bit about our current programs. This is a current hospital in Gematoli camp in which Tae-Eun and I visited in June. As you can see, it's an intensive care ward for pediatric patients. And this is built right adjacent to the camp, so people can try to access it. In Cox's Bazar district, we have 8 facilities, and we provide a range of specialized care. You know, if you look at the scope, I honestly, I struggle with sometimes imagining the scope of our operations, even having just been there. I mean, to think that we're managing over 700 outpatient consultations every year. You know, that's 2,000 people per day coming through our our different facilities, and they're receiving a consultation with a healthcare professional, either for a chronic disease like diabetes or hypertension, emergency care for somebody who got in a car accident, or victims of violence, women who have been raped, or women coming in simply for an antenatal care consultation prior to giving birth. And we also actually have quite robust water and sanitation programs in the camp, in which we provide water and sewage services for large sections of some of the camps. So it's not just one camp, there's many camps spread out across Cox's Bazar. But there's one called the mega camp, in which the majority of the population live. I could go into a whole separate dive on that, but I'll try not to and stick with the program discussion. Mental health is very important. And if you'll see in the op-ed from Paul McFun, during our trip, we talked a bit with mental health practitioners that we have there. And it's extraordinarily frustrating for them because you can't actually treat the underlying cause of their symptoms. So they can come in and have a counseling session, but ultimately we have to send them back to the very same conditions which are causing a lot of their mental unwellness. So for psychosocial care workers, it's very, very challenging because you can't actually heal someone if you can't change the dynamics in their life that are creating some of the issues in the first place. Since it's frustrating work for them. We also refer, well, here it is, 4,500 assisted deliveries in MSF facilities per year. And we have over 20,000 admitted for inpatient care, which is like the slide you saw previously, where they come in and they have a bed in a hospital and they have more advanced specialized care. And this is often where we have a mix of Bangladeshi doctors and nurses and international doctors and nurses who work together to provide high quality care. And all of these services are also accessible to host communities. So when I say we treated 700,000, I do have the breakdown, but I don't have it here. But a percentage of that is Bangladeshi, and a percentage of that is Rohingya. So most of these services, depending upon the location of the facility, is accessible by both. So moving on to Rakhine, where we've been since 1990. I put 94 here, but I do believe it's actually 1993. I'm sorry, I didn't fact check my own slides. It is 6 in here. So we started providing healthcare in Rakhine State in 1994, and we actually started by working with the Ministry of Health to malaria eradication, because malaria was quite common morbidity in Rakhine State. And we started just in general for the whole population and working with the Ministry of Health to do malaria abatement, which was largely successful. And through that, we were exposed more to the plight of the Rohingya and began working with the Rohingya. And it's prior to 2012, when there was the ethnic violence, it was quite a massive program. And over the years, it's actually reduced in size because of the population shift of the Rohingya out of Bangladesh. So currently in 2021, last year, we carried out 60,000 primary healthcare consultations, 6,000 reproductive healthcare consultations. So that means like an antenatal care, pre-birth or postnatal care after birth, or in referring a patient for delivery to one of the hospitals, and we also provided 2,300 emergency referrals. So also, if you think a little bit about the difference between Bangladesh and Myanmar, there's 1 million Rohingya in Bangladesh, there's 600,000 in Rakhine. Why are the numbers so different? Why we'd love to have the numbers be much higher in Myanmar, but why aren't they? And it's because accessing these populations in places like Mra'u, Minba, Pokta, Sitwe, Budadang, Mongdao is very difficult. The amount of negotiation that goes into simply getting a healthcare team to a village is immense. You have entire teams of people that have to meet with dozens of officials and get dozens of stamps. and it's extraordinarily difficult to work in northern Rakhine State. Whereas in Bangladesh, it has its own challenges for working, but we can build a hospital next to the camp and people can access it themselves with some challenges as well. But just the difference in the challenges in working are being so different between the two, it means that our access to the Rohingya population in Rakhine is much more challenged. And also the quality of the services or the referral services that we can provide is different. So that's the difference between the two. And we also work in Malaysia. Malaysia is at the moment one of the sought after destinations for the Rohingya living in a situation of hopelessness in Myanmar or Bangladesh. They think that if they go to Malaysia, they will be able to make money and maybe have a bit of hope for the future, maybe get registered with the UNHCR and be settled to the US. But actually it's extraordinarily difficult life in Malaysia for Rohingya. They're treated as illegal migrants. They don't have very good access to UNHCR. It's very difficult for them to get registered. And at the moment, there's quite a bit of xenophobic rhetoric in the media. But we have a very interesting program there. And we have, about 11,000 outpatient consultations. Like I said before, these are your general doctor visits for what ails you and to get some take-home medicine. We also provide 2,000 antenatal consultations. And these are really important in Malaysia because through the antenatal consultation process, we can identify women that have a high risk for delivering a baby. But the issue in Malaysia is if you are not registered with UNHCR, you don't really have access to health services because you fear going to a hospital because you could be arrested and put in detention. And there's over 17,000 Rohingya in detention facilities in Malaysia. Or if you do manage to go to the hospital, you have to pay like 100 times more than a Malaysian would have to pay. So one of the things we do there is we identify high-risk pregnancies and we refer them to UNHCR, get them registered with UNHCR, and then get them into the hospital where they get a 50% discount on the delivery, which I believe we also cover the cost of that. But that's an important thing because in Malaysia, that means like 30% of all the Rohingya get registered in Malaysia with UNHCR actually come from our medical services. So it's quite an interesting little dynamic and something that we're quite proud of. Obviously, we also do mental health consultations with a lot of the Rohingya in the detention centers. We work there as well. And as you can see, the referrals to secondary care, that's also including the women that need to deliver in a safe place or people that need emergency care or things like that. But that's all tied up with ensuring that people have protection to go and aren't going to be arrested and detained indefinitely in these not very nice detention facilities. So that's where we're currently working with the Rohingya in Bangladesh, Myanmar, and Malaysia. There's also Rohingya in India, 40,000 who are facing quite a bit of persecution. There was recently forcibly repatriations to Myanmar. The Indian government has taken quite a xenophobic approach to the Rohingya. And we recently conducted an an assessment of that population around Jammu, and their situation is quite bad. We're trying to discuss internally how we might navigate a way to do something about it. We need to learn more about what's going on in Pakistan, but people have been there largely for several decades and they're more established. And in Saudi Arabia, they've been living there for decades as well. It's less urgent. There's also Rohingya hiding in Indonesia and Thailand, throughout the region. They also try to hide that they are Rohingyas. They're also hard to find because they have to be careful of not getting sucked into the smuggling rackets. Because one of the issues in Southeast Asia is that they very much run the risk of being kidnapped, imprisoned, and then having them money extorted from their family from trafficking networks or being arrested by authorities. So by identifying as Rohingya, they become hyper vulnerable to that type of predatory behavior as well. So while they often, at the moment, Rohingya seek out trafficking networks in order to try to take a boat to Malaysia or Indonesia, or through land routes. They also have to be careful that anywhere along that line, it could go wrong for them and they could wind up in quite a horrible situation. So it's quite, and these are all these routes of getting out of Myanmar and Bangladesh have been kind of cut off in recent years, where it's becoming harder and harder for them to go anywhere or do anything. And that's creating a situation where they're getting quite desperate to say, well, what's next? What can we do? There's no hope for the future, and it's causes them to take even greater risk and be more vulnerable, and it's a very vicious cycle. So we're deeply concerned about how things are progressing. And in Paul's recent op-ed, I think we did a good job of challenging regional governments to think about their policies and try to have more humane asylum-seeking policies, because the key with the Rohingya is they're fleeing persecution for their identity as Rohingya. So it's not, they're different than economic migrants. They're much more vulnerable because they have no rights where they're coming from. It's not like they're leaving a situation in search of more of financial gain or employment. Irregular migration is something around the world we see for economic opportunity, but they're literally fleeing for their lives and from quite horrible situations, and they deserve special protection regimes in order to get the kind of care that they deserve, but they often don't get. And I think that concludes my presentation for today, and I can open it up to questions. Thank you so much, everyone. I will stop sharing my screen now, I think, and come back, or somebody stopped sharing my screen for me, which is really nice.
네, 발표 정말 감사드립니다.
Thank you very much for your presentation. I think, as you mentioned before, it's just a little bit over 6 a.m. in the US, in the East Coast, and you've been on with us since 5 a.m. for the rehearsal. I really appreciate the great presentation, despite the very early time that you're joining us today. So now we would like to take some time to answer the pre-registered questions and the questions you've sent us now during the briefing. And please understand that we cannot cover all the questions due to time constraint.
먼저 질문을 미리 받았던
Okay, so we did get a few questions in advance. So let's start with the first question. How has the COVID pandemic for the past 2 years affected the Rohingya refugee camps? What has been the biggest change in MSF's activities due to COVID? We would like to get your insight into that.
Did you want me to go through some of the prepared questions?
Jason, are you not able to hear us?
전달이 잘 안 된 것 같은데 혹시 지금 전달이 되고 있을까요? 아닌가요?
지금 영어, I am speaking through the English channel. Just let me know if you can hear. Please check the English channel, your language setting. How has the COVID pandemic for the past 2 years?
잠깐 영어로 그냥 질문을 드리도록 하겠습니다. So for the last 2 years, there has been this big pandemic all over the
지난
world. And we believe that
2년간 코로나 팬데믹이 로힝야 난민 캠프에 어떤 영향을 미쳤나요? 코로나로 인해 국경 없는 의사회 활동에 어떤 영향이 있는지.
MSF has been responding to the changes.
So just for reference, I'm only hearing Tae-Eun. I don't hear anything else. So if it's not in the chat or coming from Tae-Eun, I'm not actually hearing it at the moment. So speaking from personal experience with COVID, I was in Myanmar up until January this year. I was working there. Last year, the Delta wave hit Myanmar very hard, and I actually was managing our emergency response to COVID in Myanmar. We we really struggled with COVID as a disease because it strikes the most vulnerable in the entire population, which makes it very hard to find those people. They have to find you more than you can also find them sometimes. And we also, with the way the disease evolved, we thought that our assumptions in preparing for being able to provide oxygen for 60 people and open up a center was just absolutely, we thought we were prepared and we completely were not prepared. It really was quite challenging. I mean, our staff started getting sick at the same time as the population is getting sick. So, there was no protection of being fully vaccinated and having some of the additional protections you have sometimes going into a population that has higher health needs, like a refugee camp. For example, if it was a cholera outbreak, we would all be protected from cholera and have safe water. But with COVID, we're all just exposed as well. So we were trying to respond, but also our staff and their own families were becoming ill. But we did manage. We started quite 4 different facilities in Myanmar, and we learned a lot as we went, because one thing we also thought was just about treating COVID, but then it became about treating all the comorbidities that people came in with, because people that need to be hospitalized for COVID often have heart problems, they have diabetes, they have a lot of other things in their life that makes them more susceptible to extreme COVID infection. So we also needed then to pivot and treat those illnesses, which maybe we weren't prepared for. So we found this throughout the world, and it was quite a learning experience for us. We expected COVID to really impact people living in camps at a very high level, but we found that often the needs weren't as high in refugee camps as we often thought they would be. One of the theories around that is often because the overall population is younger in those camps, and so more easily able to survive COVID. Throughout the world, we scaled up activities to respond to severe outbreaks in Myanmar, Syria, Yemen, Peru, India, Brazil, South Africa, Europe as well. We actually worked in Europe, which was different for us. And we managed in the end, but yes, it was a very different type of intervention for us, and quite a learning experience. I'm being directed in the chat about having to press a button, which I'm not sure where it is, but anyway, please send the next question while I'm trying to do that. Yeah, I don't see. Oh, interpretation button.
네, 감사합니다.
Okay, got it.
아, 네, 다행입니다.
Now, yeah, great. Okay, thank you very much for your answer. Now I think we can move on to the next question. So I think there were also a lot of insight into the situation in Myanmar. So there are probably still people living in Myanmar, Rohingya people that are still left behind. Are they still exposed to persecution and discrimination? I am curious about the current situation for those people there.
Yeah, absolutely, 100%. Nothing has changed for the Rohingya inside Myanmar significantly. They still are not citizens. They still have difficulty registering their children. They still have, difficulty getting birth certificates, marriage certificates. They have difficulty finding permission. They have to pay bribes to move from one village to another. Life is not easy in Myanmar for Rohingya. However, since the military took power in 2021, and the Burmese population of Myanmar has suddenly is at war now with the military as well, which is a historic shift in the country. There are some changes in the way they're perceived by the Burmese, and there is more recognition for how they have suffered over the years. So there are some small indications of hope that there can be a brighter future, because now the rest of the country feels the pain that they've felt for 50 years under the being at war, the current news of what's happening in Myanmar. We also published a very interesting first-person piece from one of our staff in Northern Rakhine State talking about these things. I imagine that it is available in Korean. If not, we can certainly get that translated and out on the MSF Korea website. That came out about September last year. And you can read it in his own words, how he describes the hope for hopefully for something to change. Thank you.
네, 답변 감사드립니다.
Thank you very much for your answer. And I think the document that you mentioned, it's not translated in English yet, Korean yet, but it's a public document. So I think you can search online and you'll be able to access that document. And I'd like to add those information to you. Moving on to the next question. So how is the current humanitarian situation in Bangladesh, which is one of the least developed countries in the world? So is MSF providing medical and humanitarian assistance to the local communities as well?
Yes. Like I mentioned in the presentation, I worked in Bangladesh 10 years ago, and we opened up our hospitals to the local population, which also had very difficult access to quality healthcare. And that's remained the case for 10 years. The bulk of our programs in Bangladesh are for the Rohingya refugees. We do have a small program in Dhaka, which works in the poorest ghetto in Dhaka, where there's a lot of the sweatshops and where you have a lot of people working in very difficult industrial conditions. But by and large, Bangladesh is a fast developing country that wants to become a middle income country from a low income country. There's a development arc in Bangladesh. And these are the needs in Bangladesh as a whole is more of a development issue rather than a humanitarian issue in which, we have the Rohingya who have fled of violence in Myanmar. So we also have to differentiate a little bit between what our objectives are as a humanitarian NGO versus broader development goals. In Bangladesh, the poorest Bangladeshis, and there are many, have very difficult issues in accessing quality healthcare, in having enough money in order to pay for cesarean sections and these type of issues. For example, it's also very much a country prone to natural disasters and flooding. There was recent flooding in the northeast of Bangladesh in the Sylhet region, where we actually sent a small team to help with working in partnership with some local organizations to try to do some relief. So Bangladesh is very much would prefer to be seen as a fast developing country on the road to middle income, and is proud of that. And they do have quite a heavy, large civil society organization that's well organized with local Bangladeshi organizations like MSF that do respond to most of those type of needs. BRAC is an excellent example of that. BRAC, they're a huge Bangladeshi organization that responds to a lot of those needs inside Bangladesh. So I hope that answers your question. It's a good one. It's a difficult question to answer.
네, 답변 정말 감사드립니다.
Thank you so much for your answer. And you did mention briefly, but I'd like to add on. And I visited Bangladesh 2 months ago, less than 2 months ago, I visited Bangladesh, and I visited the hospital, and I also visited ghetto in Dhaka, and there were people who are suffering the diseases, frequent diseases. I observed how MSF has been providing support for them. And as in Cox's Bazar Hospital, it is also open to the local community members. And because the local community members were also suffering similar diseases, so they were sitting side by side. When Jason mentioned about the situation, that it reminded me of the visit there. Okay, moving on to the next question. It's a question on a specific disease, and you might have heard about it on TV or also through the newsletter that we sent out. There is diseases that's found in these tropical countries called scabies. And this, I heard that there's been an unprecedented surge of scabies cases in the camps. How is MSF responding to the spread of scabies? And that's the next question.
Yes, scabies is an absolute scourge in the camps. We estimate, or the health sector estimates, that about 10% prevalence rate throughout the camps. It's overwhelming, actually. We've actually had to cap the number of people that can receive scabies care on a daily basis in our hospitals because they were overflowing with people seeking a cream and pills that you provide in order to try to treat the infection of the mite in their skin. But again, that doesn't actually solve the problem in a camp of 1 million people when you have such high prevalence, because you send them back into the camp where the beddings, clothings, and things like that can be contaminated. And in order to actually eradicate scabies, like if you had scabies in your home, you would wash all your bedding in hot water, you would wash all your clothes, you would scrub everything down, and you would put this lotion on, and it'd be done. It's not an issue really in a resource in a country like Korea or the United States. But when you're actually living in a refugee camp, it's almost impossible to do that without a massive public health intervention, which is something that we're actually talking now with the health sector about. Because there is the possibility of doing a mass drug administration in the camp, as well as pushing for some increased access to water and some public washing things or something like that in order to try to solve the issue. But if you look into scabies as a whole, one thing that I've learned is that actually scabies is also kind of considered a neglected disease because it actually impacts resource poor settings very, very significantly. And it's often kind of discounted as maybe not that serious. But actually in a resource poor setting, it is quite serious. And there can be actual health outcomes later on in life where you're impacted, like your liver function and things like that. So it was something I learned quite a bit about as well. But it is absolutely, I mean, sitting in the scabies ward in Gematology Hospital, these kids are suffering, and these women, and God knows how much they were suffering underneath all of their cover, because Rohingya, a lot of the Rohingya women wear a lot of cover, so you actually don't know the extent of their infection, but you could see it in the kids, and it was brutal, huh? Can't imagine. Okay. I see there's a PhD student from the UK who are asking if you could share your email address. Okay, that's in the chat to everyone, I think, as well. Next question.
네, 안 그래도 지금 그 질문에 대해서
Yes, I think I was going to bring up that question, actually. I do want to add something about scabies. I think because it's quite new, not well known, it's also important to raise awareness, like health promotion, and MSF is doing exactly that. And I also had the experience to see how they were suffering, and it was excruciating. So I think if you don't go through it, you cannot actually feel the pain that they are going through. So it's really important to try to have empathy. I think we did get a question from somebody studying in the UK, a PhD student. He said that he or she is doing research on refugee mental health. The person is also asking, are there volunteer opportunities with refugees in Bangladesh? It's coming from a very warm heart. We appreciate that. Are there such opportunities?
With MSF, I mean, yes, we have our open recruitment for mental health professionals and doctors and nurses and logisticians and accountants and various skill sets. There's recruitment through the UK office, through the Irish office, through the Korean office, and we have quite a strong need for more volunteers. It can be sometimes a bit of a challenge to get through the selection process. It's quite competitive, but there's absolutely many opportunities for work. Those do tend to be for people who are later in their career, who can bring experience as well. Because, one of the things we see in Bangladesh is a good example of that is in fast developing countries, there's also quite a heavy pool of people with lots of skill sets in those countries and education that also need work. So I think over time, our staffing has changed and aged over the years, where we bring in more people later in their career who often are in position of teaching. With doctors particularly, we see a lot of doctors come in and they're managing a team of doctors and doing trainings and classes and things like that to bring to improve skill sets and things like that. But there are many opportunities, and we'd be happy to share more information.
네, 답변 정말 감사드립니다.
Thank you very much for that answer. I think the person asking the question, we also very much appreciate your interest as well. If you do have any interest in working with the MSF, participating in our activities, and if you want to do volunteer work, please reach out to the regional office of the MSF in your country. You can go to the website and there will be a detailed explanation on the process. Such on-site people who are dispatched, for example, mental health experts, people who are working in logistics, we have specific roles. So I think there will be detailed information on the R&R, how the selection process would be. You will be able to find that information. If you come into the MSF Korea website, we will provide a detailed explanation for your reference. Now, I think we will be able to take one last question due to time. Actually, no, I was told that we don't have the time to have one more question. I think there was the question on what Korea could do more to help Rohingya, but I think I would have to just wrap it into my closing comment. So for this question, we would have to just go into the closing. Thank you.
거의 새벽이죠. 미국에서 이렇게 저희와 함께 해주신.
So thank you so much, Mr. Jason Mills, for being with us today at such an early hour in the US. It's such an honor that you were with us. And thank you so much for sharing your insight, sharing the things happening in Rohingya. And we will continue to support your work going forward. Ladies and gentlemen, this brings us to the end of the webinar we put together to commemorate the 5th year since Rohingya exodus. It would be hard to get the pulse of humanitarian crisis around the world as we live our busy day-to-day lives. However, even at this moment in Cox's Bazar, Bangladesh, there is Rohingya refugee camp which is filled with people 24 hours a day, 365 days a year. And there are children growing in the camp, broken-hearted parents watching their children grow in the camp. And also there are many patients fighting with various diseases. And there are elderly who remember once when they had a citizenship in Myanmar and who are dearly wanting to go back to their country. I hope today's webinar served as an opportunity for you to remember the crisis of Rohingya people, and I hope you can deliberate on how to expand humanitarian efforts in your daily lives. Thank you everyone who are supporting the beliefs and activities of NSF, and thank you everyone who've joined us in the midst of our busy schedule. I would like to extend our deep gratitude to all of you. And of course, and also like to thank Mr. Jason Mills once again for presenting on the plight of Rohingya despite the time difference. If you have any other follow-up questions, and if you want to find out more about MSF's activities and our operation, please feel free to visit our website, msf.or.kr. And please continue to support MSF's activities going forward. Thank you so much.